I'd like to also have a little chat about the management of chronic venous insufficiency skin changes, that thickening of which is a range of leg or ankle problems that occur in the gaiter area. Slight swelling to slight thickening to severe thickening, lipodermatosclerotic skin changes, with pigmentation to actually frank ulceration and breakdown. Now clearly the treatment structure has got to be aimed at trying to reduce the risk of that progression. As the progression develops, it can be controlled or reduced two ways. First of all, by wearing stockings, graduated compression stockings, and secondly, removing any superficial veins that are not working, incompetent, a varicose vein operation. Stockings. Gosh, a lot of stuff is written about stockings. The best stockings for a patient are the ones they'll actually wear. So it doesn't matter what you prescribe, you have to check that they're actually wearing the ones you've given them. I personally prefer those that are below the knee, because I think, that is below the knee, not below knee, that people are actually more likely to wear that. Class 1 or Class 2, which is a compression that usually they can get on. And they need to wear them at all times when not in bed or when not washing, and they need to be replaced every 4 to 6 months. If the patient's already developed a venous leg ulcer, then the treatment is different. It's twofold. First of all, the management of the wound, and secondly, the management of the venous disease. The management of the wound, or both these, are managed ideally by specialist nurses, tissue viability nurses. And if as a general practitioner you're lucky enough to be in an area of the country where there's a good tissue viability practice, then hold on to that, because it's very heterogeneous across the country. The idea of managing the wound is to convert it from a dirty, sloughy, pinky, yellowy coloured wound to a nice pink fleshy wound. And this is usually done by using different dressings and removing the dead tissue. But can use more extreme techniques, such as using maggots, and ideally using the ones that are in the bag, or the so-called tea bag, which you can buy over the counter and buy from in this country and place on the wound. Usually when it's nice and pink, the wound, it's left to heal up. And again, the tissue viability nurse in the practice, or the specialty tissue viability nurses that work with us, will be able to let that heal up with adequate good treatment. But occasionally they need to be referred up, and then we undertake a skin graft, split skin graft over the wound. So that's management of the wound itself. But if we look at the management of the venous disease, again it involves management of some form of compression, but usually it requires compression bandaging. Compression bandaging is a well-established technique, been around since the ancient Greeks. I think it was Philoctetes' wound was first managed with this. But again, it's heterogeneous. The provision of care is very different across the country. And good tissue viability nurses, both in primary and in secondary care, are vital to undertaking this. The compression bandage is placed on and needs to be replaced regularly. And the second way of managing the venous disease is the management of removing any superficial veins that are incompetent, not working. That is, removing varicose veins. We've talked a lot about indirectly about removing varicose veins. So what I wanted to do is talk for a minute about who should have their varicose veins removed. Varicose veins have a variable distribution, or come under any veins in the legs. A varicose vein, a true varicose vein or a trunk varicose vein, is a large vein that pops out of the skin, and so when the patient stands up you can see it from a distance. This is different from the fine reticular veins, which are less than a millimetre or so, and those very fine thready veins on the leg. The last two, the reticular veins and the thread veins, tend to be more cosmetic. That's not to say they don't need to be treated, but they're a cosmetic cause and don't cause the aching, the itching, the throbbing, and don't cause the other problems such as phlebitis and venous ulceration or bleeds. There is good evidence and nice guidelines to suggest that people who have quality of life issues, aching, itching, throbbing, and possibly severe cosmesis, should be considered for varicose vein intervention. We should also consider the patients who have resolved phlebitis and have residual varicose veins, and patients who have venous leg ulcers that have resolved, or even skin changes like we talked about earlier. When the patient's referred up, and that's to any vascular unit, the patient, if considered appropriate, will have an ultrasound scan, a venous duplex scan. This is usually done by a vascular technologist, and then the appropriate vein is removed from the superficial vein is removed from the system. This can be done in 3 ways. The old-fashioned classical high tie and strip, where the cut was made in the groin, the vein was found, a wire was passed down it, and the vein was pulled out. That tends not to be done so much now. Another way of doing it is to put glue or foam sclerotherapy into the vein and stick it together with bandaging. And the third way is to heat the vein up, endothermal ablation. The wire is passed up the vein from either the ankle or the calf, and at the tip of the wire there's a heater, which comes either from a radio frequency or from a laser. So when our patient says they want laser, really they're just having endothermal ablation. And the NICE guidelines suggest that endothermal ablation of those 3 techniques is the best technique. Quick day case, often done under local anesthetic. So to conclude, venous disease probably affects 50% of us over the age of 50, can have significant morbidity but minimal mortality. With careful selection of patients, most can be managed very successfully in the community, but a certain number need to be considered for referring up, may need to consider complex management of wound leg ulcers, or to consider venous surgery.